Health insurance in the United States did not emerge from a grand design. It emerged from a series of institutional accidents that hardened into a system. To understand why employer-based insurance dominates American healthcare, we have to begin with a simple fact. Health insurance was not originally about employment at all. In the early 20th century, most medical care was paid for out of pocket. Hospitals were charitable institutions. Physicians were independent professionals. There was no mass insurance market because medical costs, while significant, were not yet catastrophic for most households. That changed during the Great Depression. Hospitals faced declining revenues as patients delayed care they could not afford. In response, a group of hospitals in Texas introduced a prepayment plan that allowed subscribers to pay a small monthly fee in exchange for guaranteed hospital services. This model stabilized hospital finances by smoothing cash flow and reducing demand volatility. That experiment became Blue Cross. Crucially, Blue Cross plans were community-rated and nonprofit. They were designed less as profit engines and more as institutional stabilizers for hospitals. Soon after, physician groups developed parallel plans that evolved into Blue Shield. At this stage, health insurance was still not employer-based. It was group-based, often organized through community organizations, unions, or cooperatives. The turning point came during World War II. The federal government imposed wage and price controls to prevent inflation during wartime mobilization. Employers could not compete for scarce labor by raising wages. But benefits were not classified as wages. Health insurance became a workaround. Employers began offering health coverage to attract workers in a tight labor market. This was not mandated. It was improvisational. But it worked. Then came the critical institutional decision. The federal government ruled that employer contributions to health insurance were exempt from income and payroll taxes. This tax exclusion made employer-provided health benefits far more valuable than equivalent cash wages. That ruling was not framed as a permanent pillar of healthcare financing. It was an administrative choice, but its effects were profound. Once health insurance was tax-advantaged through employment, it became economically irrational for most workers to purchase insurance individually. $1 of insurance through an employer went further than $1 of wages used to buy insurance on the open market. This is how an institutional quirk became a structural foundation. Over the following decades, employer-based insurance expanded rapidly. Large firms pooled risk efficiently. Insurers built products around stable payroll groups. Healthcare providers adjusted billing and pricing to third-party payers rather than patients. But the system had blind spots. Employer-based insurance worked best for full-time, stable workers in large firms. It worked poorly for the elderly, the disabled, the unemployed, and the poor. This gap produced the next major institutional layer. In 1965, the federal government created Medicare and Medicaid. Medicare addressed the elderly, a population that private insurers avoided due to predictable high costs. Medicaid addressed the poor, though with state-level variation and persistent underfunding. These programs did not replace employer insurance. They patched around it. The result was a fragmented system. Employer-based coverage for most working adults, Medicare for seniors, Medicaid for the poor, and a residual individual market for everyone else. That individual market was unstable. Without employer pooling and tax advantages, individual insurance faced adverse selection. Healthier people opted out. Sicker people enrolled. Premiums rose. Coverage shrank. Insurers exited markets. For decades, policymakers attempted incremental fixes without touching the core employer-based structure. The tax exclusion remained politically untouchable. Employers had built compensation systems around it. Workers perceived benefits as earned, not contingent. This set the stage for the next major intervention. In 2010, the federal government enacted the Affordable Care Act, often referred to as Obamacare. The ACA did not dismantle employer-based insurance. It stabilized and expanded coverage around it. The law created regulated insurance exchanges for individuals, imposed minimum benefit standards, introduced subsidies, and enforced an individual mandate intended to counteract adverse selection. It also expanded Medicaid in participating states. Institutionally, the ACA accepted the employer system as given. This was not ideological surrender. It was pragmatic recognition. Undoing the tax exclusion would have required re-engineering, compensation, taxation, and labor markets simultaneously. The political and economic costs were enormous. Instead, the ACA layered regulation on top of the existing architecture. This layering explains many of the system's tensions today. Employer-based insurance remains dominant not because it is inherently efficient, but because it is tax-privileged. The exclusion distorts labor markets by tying coverage to jobs. It discourages entrepreneurship. It complicates job mobility. And it hides the true cost of healthcare from workers by embedding premiums and compensation. At the same time, employers function as de facto benefits administrators, a role they were never designed to play. Yet the system persists because it coordinates powerful constituencies, employers, insurers, providers, and workers who fear loss more than reform. From an institutional perspective, the history of U.S. health insurance is not a story of optimal design. It is a story of path dependence. A temporary wartime workaround became a permanent tax policy. A nonprofit hospital prepayment plan evolved into a national insurance infrastructure. Public programs were added to cover populations the private market could not or would not serve. Each step solved a problem in its time. Together, they produced a system that is complex, fragmented, and remarkably resistant to change. Understanding this history matters because debates about healthcare often assume the system reflects deliberate choice. In reality, it reflects accumulated decisions constrained by politics, incentives, and institutional inertia. Employer-based insurance dominates not because it is the best possible model, but because once established, it became the hardest to undo. That is the defining lesson of American health insurance. For continued institutional analysis of how historical choices shape modern systems, subscribe.